Well, like Wendy said, I'm a nurse, and I started out in critical care, and I got a background in critical care. I worked in the float pool. I literally worked in every single department in the hospital with the exception of the NICU and the nursery and in the OR. So those are only two places that I've never worked. I left that and took a special assignment on telemetry, working with Wendy. I eventually took the nurse manager position there, then left that to go to quality. I went to the dark side. I'm now what the doctors call a bureaucrat, and so I do work with the quality department now. It's not always the most popular thing in the hospital because you're having to look at policies and procedures and outcomes of the patient care and all of the things like that. So what I really want to talk to you about today is harm in healthcare, because that's a big topic. What I have to do, part of my job is I have to do investigations into every adverse outcome or every adverse event that happens at the hospital, whether that is a mortality or a death that occurs as a result of the care, or just a death that occurs, or any type of adverse event or anything like that. So I felt like it was important to come and talk to you guys. I know some of you are probably getting ready to graduate, and it's important to speak to you. I'm very passionate about nursing. I'm very passionate about patient care. I have always been an advocate for the patient, and I will always be an advocate of the patient, and we do not expect anything less of you. So I wanted to come and talk to y'all a little bit about that. And if y'all didn't know, I know this has been up here for a while, medical errors are now listed as the third leading cause of death in the U.S., okay? So nursing is a good profession, right? How many of y'all went into nursing to help people? Yeah, everybody. We go into nursing. That's a noble cause. We want to help people. We didn't go into nursing because we want to be the third leading cause of death, right? 200,000, that's a big number. 200,000 patients die every year in hospitals due to medical errors. It's a big number. There's about 5,500 hospitals in the United States that are operating right now. Up to 70% of those are preventable. It's preventable. This is all preventable stuff. Everything that we talk about today is preventable. That's 140,000 lives that could be saved if we just was a little bit more careful. Human error has been listed as of nearly 80% of adverse events that occur in healthcare systems is drilled down to be due to human error. Can you believe that? 200,000 deaths, 80% is because of human error. Communication, when you look into that, human error, what caused it? Communication, 80% of the serious medical errors involve miscommunication between caregivers during the transfer of patients. Patients are constantly moving throughout the hospital. They start in the ER, or they start in admissions, they go to the floor, they might go to ICU, then they go to the floor, or they go to telemetry, or they go bad and go back to the unit, or they go to the OR and have surgery and then go back to the floor. They have to go to dialysis, they have to go to x-ray, or they have to go to CT. They're constantly moving all over the place. Every time a patient moves, you're increasing their risk of harm due to an error for information that is not being transferred every time they're handed off to another person. 1.7 million healthcare-associated infections occur every year. 1.7 million. Not infections, healthcare-associated infections. That leads to 99,000 deaths. Healthcare-acquired or healthcare-associated infections lead to up to 99,000 deaths every year. 770,000 adverse medication event-related injuries and deaths each year. We have 770,000 adverse medication events each year. So all of y'all plan on giving some medicines, right? Everybody? When you're doing your clinicals right now, how many of you are looking up your drugs in your drug book? Everybody. And when you get done and you're an RN and you go to work at the hospital, how many of you are planning on looking up all of your drugs in the drug book? I would hope everybody. Because until you have memorized by heart every single drug that's out there and every contraindication that can be had, I need you to still be looking up those medicines. That equates to about $5.6 billion annually, those errors. $19.5 billion, this is a little bit more than the Powerball was last week. $19.5 billion annually is attributed to medical errors, and that is a 2008 estimate, and I can guarantee you that it is higher now because healthcare costs more and the claims that we have to pay out for malpractice cost more. So if there's 5,500 hospitals in the United States and we're spending out almost $20 billion a year in unnecessary costs, that's going to give every hospital about $3.5 million extra dollars a year. How many of y'all know a hospital that could use an extra $3.5 million? I know that the one that I work for could use the money. There's not any money in healthcare anymore. You can't make money taking care of patients. That has been wrapped up by the government. It's now, we're being reimbursed by the quality of care that we provide patients and their satisfaction with the care that we provide. And it is rolled into the Deficit Reduction Act. So they penalize hospitals in order to pay off the nation's deficit. So they're going to win at the game. They don't ever want to give the money up. They don't ever want to give us everything that we bill for. So we could all use $3.5 million extra every year. Y'all want raises, right? You don't want to come in out of school and get your base rate and never get a raise. You want to work with innovative products and you want to work with new stuff to take care of your patients. You want to have the best beds for your patients. You want to have the best bedside monitors and as many vital sign machines as you can use, and you know, you want all of this stuff to take care of your patients and all this fun stuff to play with and work with while you're there, but that stuff costs money. It costs a lot of money. 250,000 central line infections, okay? What do y'all know about taking care of central lines? Sterile. Scrub the hub. Anybody heard scrub the hub? All right, so we have 250,000 central line infections. Did you know that there are 62,500 deaths related to central line infections every year? So you get a central line infection, you can very, very easily die from it. That averages about $56,000 per infection. So when you're standing there getting ready to give some medicine in the line, and you're supposed to be scrubbing that hub for 15 seconds, and you think, this is so dumb. Why am I having to stand here for 15 seconds to scrub this hub? You think about these people. Think about the 62,000 people that die every year because somebody didn't stand there and scrub the hub. And you think about if that's your family member, because you want somebody to scrub the hub if it's your family member. So you need to think about those things. While you're standing there, have a conversation with your patient. Explain to them what you're doing. Make your patient more educated. Make them more aware of what you're doing. So when the next nurse comes in and doesn't scrub the hub, they can say, oh no honey, you didn't scrub that for 15 seconds. Because they're getting smarter. They're looking up this stuff online. And they're being more informed and better aware of how they're supposed to be taken care of. So it's estimated that 15% of health spending is wasted dealing with all aspects of adverse events. The most burdensome being thromboembolism, pressure ulcers, and infections. Pressure ulcers. All that stuff's preventable, right? Thromboembolism, we're talking about DVTs, PEs. Pressure ulcers, hospital-acquired pressure ulcers, infections. While in the hospital, it's estimated that 1 out of every 10 patients is harmed 1 out of every 10, okay? So let's say I got 200 at my hospital right now, then that means that 20 of those patients that are in there right now will receive some sort of harm before they leave the hospital. Can you imagine that? Out of every 100 hospitalized patients at any given time, 7 will acquire healthcare associated infections. So that same 200, 14 of them are going to go home with an infection. It's preventable. 1 million people experience falls in U.S. hospitals annually. 50,000 of those result in an injury. A fall can lead to a death. Accidental falls are among the most common incidents that are reported in hospitals. They're preventable, potentially. If they call out on a call bell, be responsive. Go see what they need. Better yet, be proactive. A lot of you, when you come out of school, you're going to be working on night shift. One thing you can do when you go in to assess your patient, ask them, Mr. Smith, I'm going to be taking care of you tonight. About how many times do you get up to go to the bathroom at night? Because we have found that our patients fall at night when they're getting up to go to the bathroom, and they don't want to bother anybody, and they don't call out for help. Matter of fact, they'll wait till the nurse leaves the room, then they'll get up and try to go to the bathroom because they don't want to stop you from going. They know you're busy, but make them know that you're not too busy for them. Ask them about how many times do you get up to go to the bathroom at night, and about what time is that. If they're receiving any kind of diuretics, you might have to be a little bit more proactive. And then say, okay, well, I'll tell you what, I'm going to come in here at 11 and 4, and I'm going to help you go to the bathroom. You're proactive. You're going to go in there. You're not going to say, is there anything else I can get you on my way out the door? As you're walking out the door, you're going to say, Mr. Smith, I'm here to take you to the bathroom. We talked about it. Remember, I don't want you to fall. I have time, and I'm going to take you. Something simple as that, making that patient feel like you don't have any other patients, and he is your main priority, could save his life. 10 million cases of VTE every year. So we mentioned a while ago, VTE, venous thromboembolism, that's hospital-acquired PEs or DVTs. In the U.S., VTE-related events kill more people than AIDS, breast cancer, prostate cancer, and motor vehicle accidents all combined. Now that's a staggering statistic. Combined. That is preventable. So in our hospital, we have a nurse-driven protocol to where we can put TEDs on patients. We have to have a physician order for SEDs. We're working on advancing our VTE prophylaxis protocol to SCDs at the minimum. That's what most people do. We also have chemo or pharmacological agents that you can use like Lovenox to make sure that the patient is protected. It's your job to make sure that they have something, whether it's TEDs, SEDs, or they're on a chemo prophylaxis. Who wants to work in OB? Who wants to take care of all of the babies and the mamas over there? Okay, well, OB. 50% of risk management budgets are allocated for OB events. All right, that's the happy part of the hospital. You don't mess up over there. You can't afford to mess up over there. That's where the happy stuff goes on. Birth-related events account for more than 75% of claims paid that were over $1 million. Something happens over there, it's going to be a big ticket item. If it's a baby, it has to stay on our records and open for 28 years. They can sue you for up to 28 years. It gives the child all the way up to the age of majority, which is 21, plus 7 years for the statute of limitations. So we have to keep them open on our book for 28 years and have funds allocated to that we could use for raises, innovative equipment, and all that other fun stuff that we want. More nurses, The U.S. is the only country where maternal deaths and injuries have actually increased. You think we're real smart here, but we're going the wrong direction with that. Every 10 minutes, a woman in the U.S. almost dies of a pregnancy-related complication. So right now, just the time I've been talking to y'all, probably 2. 30 to 40% of near misses and severe maternal morbidities may be preventable through changes in patient, healthcare provider, and system factors. It's all preventable. Pediatrics, who wants to work with the kids? Cute little boogers. All right, well, there's an 11.1% chance of an adverse drug event happening in a pediatric patient, and at least 56.7% of these are preventable. That goes back to your medications, looking up your drugs. And when a physician orders something and you check in that book and you know that that is not the right dose for that patient, what are you going to do? You should stop at nothing to ensure that it does not get to the patient. Whether it's escalated to your preceptor, your charge nurse, the floor manager, the physician, you can take it to me, wherever you want to take it to. But make sure you don't take it to the patient. Most common types of harmful pediatric medication errors are one of everything. That's a pretty extensive list, right? The most common one being improper dose or quantity. Who orders the doses? The docs. You think they make mistakes? I've had to confront physicians over medication errors. I had one doctor ordered insulin on a patient that wasn't a diabetic. Did I give it? No. Who wants to work in critical care? Work down there with the sick people. Unplanned extubation occurs in over 7% of patients undergoing mechanical ventilation. These complications of unplanned extubations result in over $4 billion in healthcare costs. That's when the patient pulls his own tube. You're sitting right there. You ain't got but 2 patients to take care of. You can't make sure your patient don't pull the tube out. Sentinel events from respiratory depression are caused by wrong dosing 47% of the time and improper monitoring 29% of the time. So we got our unplanned extubations, we've got our respiratory depression because we overdosed them, and then we weren't watching them. Failure to rescue, failure to rescue is when you code a patient and they don't make it. That accounts for 60,000 deaths each year, and this number is only looking at Medicare patients who are under the age of 75. So that's not a big population of patients. You're talking about Medicare eligible, but they're under 75. So 60,000 of those die each year in failure to rescue, and 68% of those occur among surgical inpatients who have treatable complications. Now, this is something I have to look at every month. Pressure ulcers, post-op respiratory failure, post-op sepsis. Preventable? Pressure ulcers, post-op respiratory failure, post-op sepsis. Education of the nursing staff with the utilization of monitoring tools is what is key to the success of being able to identify and immediately intervene before the patient gets into trouble. We don't want it to get to a code. We have at our hospital what we call RRTs, Rapid Response Team. You've got to be monitoring your patient. You've got to assess your patient thoroughly and fully. You have to know their baseline so that, especially when they come out of surgery, so that you can identify right off of the bat when something starts going south with them, and you can call the RRT, and hopefully by calling the RRT you can intervene early and it will never progress to a code. Sure, codes happen. People die, but if we're really on top of our game, we're going to know that something's going on with our patient before it ever gets to that point. Well, what if I call an RRT and there's really not anything wrong with my patient? Well, I don't sit in my office and think, I hear them cancel RRTs all the time, and I don't say, well, that dumb nurse called an RRT and there wasn't anything wrong with the patient. We don't sit around and think that. We're thankful that you thought ahead to call an RRT to make sure nothing was wrong with your patient, and then we're double thankful that they were okay that we could cancel it. Prevention. Prevention of harm through adherence to evidence-based practice guidelines is the best defense against patient harm and malpractice claims. Prevention. So you'll hear a lot, and I don't know if you've heard very much in school about evidence-based practice guidelines, but in the hospital you're going to hear a lot about that because that's kind of the thing that I have to deal with. And all that is just that all of the hospitals in the whole United States, they come up with better ways to take care of patients with proven outcomes that are just better for the patient. We learn from others. There's no sense in reinventing the wheel. We just learn from each other. And that is your key to preventing harm to your patient, is sticking to a best practice standard and making that standard in everything that you do. Did you know that 29,000 people who were initially diagnosed with C. diff dies within 30 days? C. diff. They're going to die within 30 days, 29,000 of them. That is a preventable death. C. diff is highly contagious. You can take it room to room to room to room. You've got to have early identification. You've got to get your patient on isolation. You've got to follow the isolation measures. How do you prevent C. diff? Number one thing, hand washing, hand hygiene, following your isolation guidelines. Don't track it from room to room to room to room. It will go through a nursing home like that. 13,000 people die every year due to a catheter-associated urinary tract infection. 13,000. Well, if they don't ever get a catheter, they're not going to die of a catheter-associated UTI, right? So we have a nurse-driven protocol at our hospital where if they do not meet the CDC guideline to even have a Foley catheter, they can't have a Foley catheter. And even if the physician tries to keep the Foley catheter, our infection preventionists will call the physician and have a conversation with them. Because if it doesn't meet the guideline, they don't need to have it. So when you think about patients having catheters, and it's a convenience thing. It's easier on the nurse, right? You don't have to go in there and take them to the bathroom. They've got a catheter. You don't have to worry about them calling out on the call bill. Think about that. Departments where staff have more positive patient safety culture perceptions have less adverse events. Positive people. It's all about the attitude. So when you walk through the doors of wherever it is that you're going to be working, carry a positive attitude with you. You're going to have to force it some days because nursing is a calling and some of us may not be called. So when you're not really called and you're trying to do something anyway, then you're really going to have to force it. So you're going to have to force it. Not everybody has good days 100% of the time, right? You're going to have bad days. But when you come through those doors, you lay everything else aside and you have a positive attitude. You carry your positive attitude into your team and your nurse's station and the area that you're working. It's infectious. Just like negativity is infectious, so is positivity. Then you will have a positive team to work for. Your team will spread off on other people. When you carry your positivity into a patient's room, they're going to heal faster and you're going to prevent adverse events from happening. They're going to feel better, they're going to like you better, you're going to have better patient satisfaction scores and less adverse events. Saving lives by just having a positive attitude. So just touching on readmissions, you really don't think that readmissions really would be harmful to a patient, but about 18% of patients will readmit within 30 days. That results in about $15 billion in spending. A staggering 50% of post-op patients will come back within 30 days. 50% of them. Poor quality care and poor transitions between different providers and care settings are the leading causes. So you send a patient home, they come back within 30 days. It's generally going to be the quality of care that they received at discharge, or either they didn't get a good transition. It may be that they discharge prematurely. Who can prevent a patient from discharging prematurely? The nurse. You're the last person to lay eyes on your patient, right? You fixing to put them in a wheelchair and send them out with a transporter, or you're fixing to put them in a car. If they don't look quite right, if their vital signs don't seem right, maybe they had a piece of lab work that came back that wasn't quite right, you can make the difference in the life of that patient just by calling the doctor. You're going to lose some skin in the game. I mean, you're going to get chewed out a time or two, and it's going to feel sometimes like you're being crucified, and it can be painful sometimes, but you're going to have to suck it up and do what's right for the patient. Call them. Who cares? The doctors, the nurse practitioners, they put their pants on one leg at a time just like you do. You're standing in the gap for your patient. And if you know something's not right, it's your responsibility, and we expect you to notify who you need to notify to ensure that nothing bad happens to that patient. They can get home and go to get out of the car and fall out and die right there in their yard, and it's happened. They can get home and not be able to get in the house and call an ambulance to bring them back, and they're dead before they get back to the hospital. It's happened. A lot of times they go to the wrong setting. We're sending them home, but they can't work it. They could use a couple of weeks at rehab. You got case managers working on your floor with you. You've got social workers on your floor with you. Get together, collaborate with your team, communicate. We already identified communication was an issue. Communicate with one another. Get them some rehab. Maybe they're not getting the adequate information or the resources that they need at home. You start readying a patient for discharge when you admit them. There's questions you'll ask on your admission assessment that will identify what some of their discharge needs may be. Maybe they need Meals on Wheels. Maybe they need ride to doctor's appointments. Maybe they can't afford their prescriptions. You're the only one who will know that. So the U.S. spends more on health care annually than any other country, but we rank 36th in the world for life expectancy. After all these numbers we've been going over, it's really no wonder, right? So what can you do? I'm going to need for you to bring your A game when you come to the hospital or wherever you're going to be working to take care of patients. Bring your brains with you, okay? And I'm not making a joke. I'm being serious about that. You've got to be thinking. We've already identified human error is an issue. I'm in there pushing a drug, but my mind is thinking about what they're getting ready for lunch out there. I'm in here with my pediatric patient trying to give medications and don't even realize that I picked up my 86-year-old patient's medicines, and I'm in here with them because I'm thinking about the fight I had with my husband last night, and I am totally not thinking about what I'm doing. You have got to stop. Get your head in the game. Realize what it is that you're doing and focus on nothing else. When you're giving medicines, you shouldn't be bothered by anybody. That should be a no interruption zone, and your mind needs to be on exactly what it is that you're doing. Humble yourself. When you come in there to take care of patients, when you walk through the thresholds of that organization or facility that you're going to be working at, you need to humble yourself because not everybody knows everything. I don't know everything. I worked almost 20 years taking care of patients, and we still ask each other questions. When we had to do a heparin infusion or any kind of titratable drug, we double-checked each other's math. I was a nurse for nearly 20 years, and I was still asking questions and still getting Wendy to check my heparin infusion for me. You work together. You work together. You have a team. You are not an island unto yourself, and you don't know everything. You will never know everything. You can live to be forever, and you're not going to know everything. Medicine changes so rapidly that we all have to work together to make sure that nobody gets hurt. You got to protect your license. You need to protect your license as much as you're protecting the patient. check yourself at the door. Attitude is everything. Just like I said earlier, it prevents harm, prevents adverse events from happening. If you see something, say something. I know that's the big buzzwords out there nowadays. See something, say something. See something, say something. It doesn't matter how little or insignificant you think it is. If your preceptor don't want to hear it, take it to the charge nurse. If they don't want to hear it, take it to the nurse manager. You can take it to somebody. Somebody wants to hear it. Report, report, report. Everything. We have incident reporting system. We need to know. We need to know not only adverse events that happen, but we want to know about the near misses too. Because that's how we can really make a difference in the care of the patient. We want to catch things before it actually reaches the patient, because we probably have an issue with a process somewhere or a system somewhere. It's not your fault, but we need to identify what the issue is and then see if we can come out with a better process, a better way of doing things. You guys are going to be brand new, coming to the hospitals, walking in. We've been there for 20 years doing the same thing every day, the same way every day. But your fresh eyes, when you walk in, you can tell us better ways to do things. We just need to listen to you. You may identify more efficient ways to do things, safer ways to do things, and we need to hear those things. Treat every patient like it is your own family member, and I mean that. And there can be some aggravating patients, can't they, Wendy? There can be some aggravating patients out there. But you got to treat them like they are your own family members. Ask more questions. Don't ever be intimidated or afraid or bullied into not asking a question of anybody, even to a doctor. The scaredest point that I've ever had, whenever I was training a new nurse, I was in ICU, and she paused at the door of the patient's room and she looked at me and she had a real puzzled look on her face, and then she cocked her head and decided to go on in the room anyway. Well, don't you think I tore that counter down trying to get over there to her before she did something to that patient. And I pulled that question out of her. Don't ever think you can't ask me a question. You can always ask me a question. I want to know the question. There's not a dumb question. Don't ever think, well, I've already asked 25 questions today, I don't want to ask 26. Who cares? We're not keeping count. We want you to ask questions. We expect you to ask questions. So a lot of times that's the only way you can save a patient. And if somebody gives you an answer you're not happy with or you're not satisfied with, ask somebody else. Maybe you don't like your preceptor, and there may be another nurse you've buddied up there that you respect a lot that seems to know a lot of stuff. Ask them. You don't want to hurt your preceptor's feelings? Who cares? Okay? Like I said, you stand in between the harm and your patient. Okay? You stand in that gap between what's going to hurt your patient and your patient. You stop it. You don't let it get to the patient. You are the last check before harm reaches the patient. You're the last one. The doctor's done come and wrote you a bad order and he's gone. It's all on you. It's very weighty. When you're dealing with people's lives, their beating hearts, and they're literally everything to somebody, okay? It may not be nothing to you, but they are literally everything to somebody else. And you are wholly and ultimately responsible. And it can be very, very weighty. And when bad things happen, and they do, because we've looked at all these statistics, right? So how many of y'all think that you're probably going to harm somebody? Well, you probably are. Nobody's raising their hand, but you probably really are, according to the statistics, right? We got 14 of them right now at the hospital supposed to go home with an infection, and 20 that's going to have something happen to them. So somebody's doing it up there at the hospital right now, right? That's just at one hospital. We don't set out to do it. We don't want to do it. We don't mean to do it. But it happens, okay? We have to be careful. You got to have eyes wide open at all times. You have to be vigilant about what you're doing. This is serious and weighty stuff. I've sat in depositions with new nurses that came out of school, accidentally hurt somebody, gave up nursing. It's hard. takes really hard on people. I don't want that to happen to y'all. You've worked really hard to get where you are. You don't want to give that up, right? You got to fight for that as much as you would fight for your patient. So all the numbers that I throw out there, because I'm just really into statistics, those numbers are these people right here. They're numbers, but they're really people. There are patients. They're the family members and the loved ones of your family. We live in a small community. You're going to know half the patients you take care of. You're going to run into them at Walmart. I still do run into patients that I took care of at Walmart. You're going to run into them in the community, and you're going to have to face them and make it be good. So all those numbers and all those statistics, they boil down to one thing, and that's those people that are behind those doors that we all come to the hospital for, even administration, because if it wasn't for those people right there, there would be no need for us to even show up. And hospitals are being shut down left and right due to bankruptcy. They can't keep their head above water. We've got to do everything we possibly can to provide the best, most efficient, safest care that we possibly can when we're there. So that's all that I have.